Hello, welcome to the how-to webinar on virtual case management. This is part of a 5-part webinar series on how to take HIV services online, supported by PEPFAR and USAID. Today we are on our 3rd webinar, and we have 2 more scheduled in the future in August and September. I'll send those registration links in the chat here, just in case you are interested to go ahead and look at those. So hello, my name is Benjamin Eveslage. I'm a technical advisor for online HIV services at FHI 360. I support our global and bilateral HIV programs, mainly funded by USAID and PEPFAR, to utilize online and virtual platforms to support HIV outreach, referral, clinic tracking, and case management. So let's start with some logistics. Go to the next slide. So attendees will be muted by default, and other panelists should stay muted unless speaking. For this webinar, we will use the Q&A feature. There's a button called Q&A. Submit your questions there. It'll be easier to track for our side and provide you responses to your questions. You can send other messages in the chat function and make sure to select to all panelists and attendees. And let's just test that. Please write currently your number one emotion that you're feeling. Tired, energetic, caffeinated in the chat, just to make sure that it's working for you. Or you can put in an emoji. Rachel's tired. You can put in an emoji that represents your current state. Let's go ahead and test that chat. Make sure you say to all panelists and attendees. All right, and then also during this Zoom, we will be using polls that'll be embedded in Zoom, so be prepared to click or touch options on your screen. We'll go to the next slide, and we will start our first poll. So Sarah, let's start this poll. It should pop up on your screen, and we're asking, which organization do you represent? Organization or entity? And you can select any of these options: donor agency, HIV program staff, such as headquarters or field-based staff, government or ministry staff, community organization, a case manager, or other medical staff, or other person entirely. Go ahead and select the one that represents you, and then we'll continue. Give it a moment for the poll to be entered. So provide your response, and this is only for attendees. Hosts and panelists are not able to vote. All right, so we've given you all a chance. Let's go ahead and reveal the result and see who's on the call. Okay, great. Majority HIV program staff. We have some people from a donor agency, probably USAID. Thank you for joining. Some community organizations, absolutely great. Government, and some even case managers and medical staff themselves. So that's great, a good mix. This webinar really is intended for people that are involved in planning HIV services, designing HIV services, and considering bringing case management services to virtual platforms. So this is great. This mix is a really great mix for this webinar. So we'll go to the next slide. We'll just go to the next slide on the agenda. And for our agenda, we have 90 minutes scheduled. We may not need to use all of this time. And our learning objectives are really built into our agenda. So first, we will start with a review of some key concepts that we were defining for virtual case management. So we're all on the same page as to what we mean and what services are being supported by virtual case management. And then we'll move into a activity that we're calling a Fishbowl activity. And this is where you're really going to learn from the field around how they're implementing these approaches. And it has a very unique format that we're going to try to test out with you all. So we'll get to that later. And then after we have that Fishbowl activity where you're really learning from real implementation, we're going to take it back to the global level, and we're going to review what we're planning and documenting in a forthcoming virtual case management guidance document. And that includes planning and rollout steps, procedures for virtual case managers along various steps of the HIV services cascade. And we'll end with Q&A. We'll go to the next slide. And we're going to start with some key concepts. Next slide. So for this presentation and for the topic of virtual case management here, we're really focusing on certain parts of the HIV services cascade. And we'll get into a definition of case management itself, but here I just wanted to highlight really what are the components in the cascade that we're talking about. And here we have inside the red, this is the HIV services cascade, from identifying people at risk for HIV, reaching them, testing people and helping them know their HIV status, and then to linking people at high risk for HIV and HIV that are HIV negative to PrEP and retaining on PrEP as needed, and people that have been diagnosed HIV positive to initiate ART, sustain an ART, and reach a suppressed viral load. So the primary objectives for virtual case managers here is really on this biomedical prevention aspect of PrEP, supporting people throughout that aspect of clinical care, and people living with HIV in the ART cascade. So there's four main sections or stages of case manager support, and it can be one, the linkage from knowing your HIV status through counseling and to linkage to either PrEP or ART. That's one. The second is the PrEP cascade. So from initiation of PrEP through support to prevent HIV acquisition. The third, is linkage of people HIV to ART and support through that cascade. And another component of the ART aspect is partner notification support. So clients that have been enrolled to ART supported to use a variety of approaches that they can use to notify their partners and bring them in for HIV testing so that they also can know their status and enroll in PrEP or ART. So those are those four components. We'll go to the next slide. So you might be asking, why virtual case management? Well, I think we should first ask, why case management? And case management, at least presented within this document, is really a client-centered, tailored approach that is systematic and offers quality follow-up services to clients. So it is preventing this dropout between different providers, and it's preventing dropout across the cascade. And it also supports transparency and accountability within an HIV program for who is truly responsible to support a client for a certain clinical goal in their clinical journey. So we're really, with this concept of virtual case management, we're really trying to close all those gaps and ensure accountability of who is really providing support to this client across the continuum. So then the second component is why virtual. And there's a couple of reasons. I think a lot of reasons why you're on this call today. One is to really better connect with the growing user base of online and mobile platforms. As I'm sure you're aware, use of social media and the internet and just mobile devices have really increased over the last 20 years. And over 50% of the world is already connected on a variety of social media platforms. And it's just becoming the way that you stay in contact with people and even support behavior change and learning about services. So it's just a better way to connect with that audience. The second is that many clients, especially among key populations, have a higher preference for private and confidential engagement and maybe adverse to going into an HIV-focused physical setting to receive some of these services because of stigma, discrimination, and or just a need for or a preference for more privacy. So a virtual communication, phone-based conversation can be more convenient and seemingly more private for those individuals. Also, and I think the reason why so much of our learning in the HIV sector is being done online now is because of COVID-19's limitation on being able to meet people physically. We don't know exactly how long these lockdowns and physical distancing will last, and they might, they might free up for a period, and then they might be re-implemented as the COVID-19 pandemic has resurges in certain areas. So virtual channels will likely, at least for now, and likely well into the future, be a very important vehicle to stay in contact with clients. Okay, we'll go to the next slide. So here's where we're really getting into what is virtual case management. And we did want to put together a framework, a set of components that would give a certain level of quality and standard to what we mean by this approach. And so here we have 4 characteristics, 4 little puzzle pieces on the figure here that are components of case management. And they are all supported through virtual channels, either primarily or partially. And so we have 4 different pieces here. And I'll go into each of these in depth. We'll go to the next slide. So what do we mean by virtual? So this is when part or all of the support services provided by case managers is not face-to-face. So this will include this needs to include virtual channels, some of which are online, but not all of them are online. So an example would be, so the way that this works is that virtual is a broader category of non-face-to-face channels, and online is a subset. Some things that are virtual but not online would be phone calling, SMS. And then those that are online would be those mobile data-based messengers like WhatsApp, Facebook, or other social media platforms, possibly dating apps, and then telemedicine such as video chat, etc. However, for most of these situations, we really are talking about phone-based support. Phone-based support either by voice calling, SMS, or an application on your phone. We're really not talking so much about email or other virtual channels like radio or TV broadcasting, obviously. This is a one-on-one approach, and one of the ways, the real main way where people do one-on-one virtual engagement is through their mobile phone. So go to the next slide. And this is starting with those 4 main components. So the first one is tracked. Case management needs to be tracked. And this is really using an electronic case management system to individually track clients, document their service uptake, and case managers use this to guide their support to clients. You can see a screenshot of QuickRes, which we'll demo later. And this system allows appointments that are booked online by clients to be assigned to certain case managers so they can view the client's status and help follow up with that client over time. There are many different kinds of case management systems that can be used. The one you see here is QuickRes. It's built on a program called Aura, the online reservation and case management app. But there's other systems. There's those that are based on DHIS2. There's individual trackers based on DHIS2 that allow staff to enter information on their cohort and go back and look it up. There are electronic medical record systems and even systems that are on Excel. An Excel tool can track a lot of this information for a case manager. We'll go to the next slide. So being tracked, having a system that tracks clients over time allows the case manager to be coordinated with service delivery sites and with other case managers. So for instance, case management is a term that reflects this entire continuum of care. However, different people can take on that role at different points. There can be a post-test HIV counselor, there can be a linkage counselor for ART, an adherence counselor, and then there can be a contact investigator for index testing. So there can be various people, but it requires, case management requires that each of those people have a approved plan for when they hand off a client to each other, and they have an expectation of when that client can be handed back to them for their own support again. So coordination is a key thing, and using these tracking systems, it allows it to be more coordinated. I'll go to the next slide. Case management is also one-on-one. So to describe this, I'll say what case management is not. It's not a call line. It's not a hotline where someone can call in for generalized support for ART adherence. It is when a case manager has a set of assigned clients that they have a set goal to achieve with that client. It could be viral suppression, it could be linkage to ART. But they are responsible for that one client and maybe several other clients in their cohort to achieve that certain goal. It's not a support group either. Support group, it serves a different function, and the case manager can refer a client to support group to support the overall case management goal, which could be viral suppression, for instance. So one-on-one means the case managers do have these assignments of clients that they do support to achieve their specific goal. We'll go to the next slide. And being one-on-one, it allows the case manager to understand the individual client's status or location in the HIV services cascade and provide a tailored package of services to the client that is differentiated based on their treatment goals and the client's needs and preferences. So for instance, there's typically an intensive phase of support provided to clients from HIV positive diagnosis through initiation and maybe the first 3 months of ART. That might then bleed into a more maintenance mode of support that might have fewer check-ins based on what the client's preferences are. We'll go to the next slide. So I wanted to highlight a couple different models of virtual case management because we spoke about sort of the high-level ideals of what this framework would look like, but we do know that in the field, within programs, it can be structured very differently because there's sometimes many different actors. They can be community actors, clinical, or other third parties that can come in and provide support to clients at different parts of the cascade. So we'll go to the next slide. So first, there's three main factors that we're going to talk about. One is team format. The second is the support structure provided to the client, and the third is the channel of communication. So first, we'll start with the team format. There's three here that we've presented: community, hybrid, and clinic. So community is where community members are hired and trained to support clients across a range of other service providers. So this is an example possibly where the community staff are based at a community place and are supporting their clients who maybe they have tested, but then access treatment at a variety of other clinics. They're following up with their clients that are accessing services at other places. Clinical is where clinic-based staff provide case management services to clients accessing services at that very clinic, okay? So this can be people in routine ART care, and there's a case manager based there. And what is very common, I apologize, there's dogs in my building, if you could hear the dogs. Hybrid is where you actually have overlapping cohorts. Community has their cohort that's going to span different facilities, and they're really providing that community support that's specialized for that. And then those same clients might also have a case manager on the clinic side. And that can take a couple different forms of how the client interacts with those case managers, and we can talk about that on the next slide. Great, so support structure. So dual is where community and clinic-based staff each have their own overlapping cohort of clients that they track and follow up over time. And each uses their own case management system. So this might be used when an HIV program needs to track and report clients who access services across facilities. And an example of this, and this sounds like it's an example of bad coordination between the community and clinics, and that's not necessarily the case. It can be that clinics are typically reporting to the Ministry of Health, and they're not providing or tailoring their response to key populations, maybe because they don't want to have that data that's very stigmatizing in their systems. And so they're reporting for those purposes. However, many HIV programs really do specialize on key populations and that community support. So they have a separate case management system that's following up with those clients at the same time. And so in some situations, that is the ideal solution for being able to tell a story about case management for key populations as well as the general population in the public health facilities. There's two methods of shared support structure. One can be staggered, and this is when one client is supported by one case manager at a time, but it's handed off between different case managers. So for instance, it can start with the facility-based linkage coordinator, and then the ART initiator, and then it can hand over to a community peer navigator through adherence support through viral suppression. That could be an example of staggered. So the other example is layered. So layered is when there really is one primary case manager who tracks the client on a case management system, and they are responsible, but they might delegate some of the communication with the client to someone else. So this is an example where the clinic-based case manager has their cohort, they're following up with clients. However, they know that some clients are better supported or through the communication of a peer navigator, and that peer navigator may not have a case management system, but the clinic can call the peer navigator and say, hey, can you help me re-engage this client? That's an example of layered, okay? And the last one is singular, and singular is when there's one case manager who supports the client throughout their clinical journey. All right, so go to the next slide. And this last one is channel. And so this is really about the level at which virtual channels are used to support the client. The first example is virtual only. So case managers only communicate to clients virtually or online. And this is useful when there are remote case management teams that span various geographies where they're not even physically close to the client. Or if they're supporting clients access services at a range of other private health services or a network of services that are physical, but their virtual case management services are only done by phone. Partially virtual is the next, and this is where some, but not all of the case management services are provided or offered virtually. And some of them are offered in person. So this is when case managers are located near the clients and there is an appropriate office or clinic set up to be able to meet those clients. And when certain services are either required or generally preferred among the audience to be done in person. So this could be an example of index counseling and offer that might be done in person as opposed to routine follow-up can be virtual. The last here is client dependent. And this is where the clients can choose virtual or in-person support. And some case managers can offer, and so this can take a couple of scenarios. One, the case managers can offer some virtual, so in a cohort of case managers in a program, some can be specialized for virtual only, while others can be in-person only. And they do field visits and provide that support. And a client can choose if they want to be paired with a virtual case manager or a in-person one. Or it can take a different approach where each individual case manager can divide their cohort into those that they're talking with virtually or those they meet in person. And they can use their case management system to know which clients they need to meet with in person and which ones are just going to be by phone. All right, so that summarizes the different models of virtual case management that we are framing. And we'll go to the next slide. And we're going to do a poll again. We've thrown a lot of information at you, and we just want to be sure that you're capturing it, and we want to get your engagement on this. So what do you think of this framework for virtual case management? All that I said the last 20 minutes, I've given some terms here that you can use as your first reaction. So are you thinking that generally that this information is confusing, not very clear yet? Or do you think that it is quite clear, and because it's clear, it can be useful for your understanding? Or are you more on the side of thinking about these things as being innovative, new, interesting, or do you find these to be repetitive or things you've seen before or not exactly interesting? So these, of course, aren't mutually exclusive buttons here. Just choose whichever comes to your mind first after hearing this now. So just give a moment for everyone to provide their response to the poll, and this will help us as we engage further in the webinar. Just give 1 minute. There's a couple seconds for you to respond on the poll. All right, and let's go ahead and reveal the poll results. Okay, great. I'm very happy that this has been clear. I do understand that this can be confusing, especially if it's not necessarily distinguishing itself from other things you've heard before. We will really appreciate any questions you have. You can put in the Q&A tool in the Zoom feature, and we will help address those. And it's our goal that when we do produce the guidance for this virtual case management, that it really does try to distinguish itself and build on existing approaches and case management documentation to be something that's going to be useful for your program. So thank you for the feedback here. We'll go to the next slide. All right. So in a few moments, we will start a fishbowl activity. In this activity, 4 people, or fish, will pretend they are merely having a private conversation with each other, speaking honestly about the good, the bad, the ugly about implementing virtual case management. And you, as a participant or the attendee, has the benefit of listening to their conversation. So it's like you are looking into a fishbowl and the fish are unaware that you can see and hear them. We'll go to the next slide. Our 4 fish bring experience planning or implementing virtual case management. The fishbowl format is meant to support your unfiltered learning about the reality of planning and implementing these approaches. So let me introduce each of our fish. Bhagwan is the project director of the Linkages project in Nepal, which has experienced a dramatic shift towards using virtual platforms for client case management for clients living with HIV using phone-based, voice-based conversations. Lucy is a technical advisor for community-based services at the Linkages project in Indonesia, where they have similarly supported a dramatic shift towards using virtual platforms for client case management, combined with new 2-month dispensing of ART and home delivery of ART using ride-share apps. So Lucy is also joined by Linga, who's on the Indonesia team and also supporting these approaches. Then we have Laura. Laura is a project director of the Linkages project in Eswatini and has been planning the introduction of virtual case management for psychosocial services that are offered to clients of their project. And last, we have Purvi, who's a technical advisor with FHI 360, supporting the Going Online portfolio. She led the design and rollout of Yes for Me in India, which is the first example of a completely online approach for outreach, HIV testing referral, and virtual post-HIV test counseling and linkage to ART and PrEP. So today, Yes for Me is continued under support from the Accelerate project, which is USAID's flagship KP program in India, implemented by JHU, YRG Care, and Blue Lotus Advisory. So Purvi will be speaking about her historical experience, her previous experience setting up that Yes for Me project. We'll go to the next slide. And you can click the animation. So fish, you have 25 minutes for the fishbowl. Laura, you can kickstart the discussion and anyone can take it from there. If there's an awkward silence, you can use the graphic on the slide to determine who is next in order to speak and ask their question to the group. When you're done, you can say thank you, no more questions from me, and I'll let you know if you're going over time. Otherwise, your discussion can end early too. After the fishbowl, we will open up the chat to send questions from the attendees to all of the fish to respond to. Attendees, please use the Q&A feature and submit your questions at any time. Avoid using the chat to avoid distracting the fishies during the discussion. So fishies, are you ready? Okay, time to channel your interacting skills and pretend that we are all not here. I will recommend that you turn on your mics and cameras if you would like, just to give it a more in-person interaction between you 4. And so Laura, go ahead, take it away. You can start the discussion.
Okay, thanks. Hi, everybody. So since the start of COVID, we've seen a huge increase in interest of going online and seeing more and more case management type services being done through the phone, WhatsApp, etc. Prior to COVID, especially here in Eswatini, we did so much face-to-face that this is a really, really big shift. And we really want to use it to kind of make sure this is one of the key features that continues post-COVID down the road. What I'd like to know from you guys, because you guys have implemented and have a little bit more hands-on experience, is with this overarching shift, are there any trainings or was there any specialized skills that you would do with the case managers to kind of talk through the nuances of the conducting virtual case management? You know, there's no more body language. How do we ensure that, you know, the the person that we're providing the services to is kind of more focused and they are multitasking. I think, issues in terms of privacy. So that's kind of one of the things I'd like to know. And second to that is, did we see any difference in terms of general time spent with the clients when it went virtual? Did it actually increase the amount of time spent with clients and the number of visits or calls that were needed, or did we see a reduction? Does anybody have any suggestions for me? Thanks.
Thank you, Laura. Yes, so here in Nepal, so after the lockdown, so we immediately scaled up use of virtual case management services, both through mobile phone or social media platforms. So before actually before the lockdown, yeah, we are also we have been using this online platform to reach key population and PLHIV, but after the lockdown, we rapidly scaled up. So, and for to support our case managers, so we provided a clear guidance and for virtual case management, and we also provided orientation. So also, yeah, so we provided communication costs to them. And so as we are rapidly scaling up virtual case management, then our program officer and our technical specialist at the Linkages Nepal country office, we regularly provided virtual mentoring, support, and monitoring. So definitely, so there is an issue of confidentiality and privacy, but so before talking with them, so we asked them so whether this is the right time for the conversation. So yeah, we are very much concerned and sensitive about the privacy and confidentiality, and then we maintain privacy and confidentiality. Yes, yes. So with this virtual use of virtual platforms, so we are able to provide virtual case management support to around 10,000 PLHIV through either social media or telephone. So around 50% of the virtual support is through telephonic conversations. Yeah. So so I'd like to also know so some of the challenges so you have faced while using virtual platform. So in case of Nepal, so because of the as almost everybody are going virtual using mobile phone and internet, so there is an issue of internet connectivity issue, and sometimes phone is not reachable. So and then some of our community-based staffs who are mostly from PLHIV community or key population community are not that much tech savvy. So these are the common challenges we face. So yeah, please. So if you have so can you please explain? So what are the challenges you faced and how did you deal with these challenges? Thank you.
I also wanted to add here, Laura. So, in India, when we started this whole virtual case management, it was not really termed as virtual case management a couple of years back. The Going Online program in India was mainly started with private facilities. They were diagnostics or laboratories that did HIV testing. But in India, when you go to a private laboratory, you do not have the facility of pre-test and post-test counseling. And so it was really upon the program that we needed to ensure that we kind of provided that support to the clients, pre-test and post-test counseling. And because this was an entirely virtual program, we started doing it online. And our counselors were trained to actually talk to people and conduct pre-test and post-test counseling. So the time taken, actually, the question that you asked about time, it sometimes went on to an hour or so for post-test counseling, especially for PLHIVs, because there's a lot of anxiety. There is, sometimes people don't accept that they are positive. So it takes a longer time. And especially when you're virtually talking to somebody who you don't really know, you haven't ever met. it gets difficult to convince the person or build that trust amongst that person. So yes, sometimes it does take a longer time as compared to a face-to-face communication. With regards to skills of a case manager, I would say that we used the counselors as case managers while doing virtual outreach, and so it all actually depends on what purpose you're going to use the case managers for. Is it for follow-up of adherence? Is it for counseling? Is it for support? Or you mentioned psychosocial support. So it all depends on that, and then your skills for that cadre will be based on your role that you think is correct. Thank you. So I also wanted to know actually from Laura, so why did you choose to do virtual case management for your psychosocial services? So what made you choose to go virtual?
Thanks, and thanks you guys for the great feedback. I think it's really helpful to kind of hear what others are doing. And I think to your question, Purvi, so one of the main reasons we went to virtual psychosocial is based on COVID. I think that was the driving factor, because normally it's a lot of face-to-face, and it's done through our community health services that were paused by the ministry. But since then, we have found that it's been working, and it's been working really well. And, I don't know if many people know about Eswatini, but we're a very small little kingdom. And you might have people that you have to go do a face-to-face visit that's like 2 hours away. And this allows our psychosocial officer to actually provide more support, because it doesn't include as much of the travel time. And I think that's the same that we see for the other, because we also do peer navigation virtually as well. So I think it started out with COVID just based on safety and trying to make sure people had access to support, because so many other services were really stalled and not opened. And it took a little bit of time to kind of get people used to the idea that it can work, especially because psychosocial is very nuanced. But so far it's been actually working very well, and that we continue to see interest in the services. So it's something that we want to continue down the road as well, just because it allows us to actually reach more people versus just a face-to-face individual. And it allows, I think you raised a great point. Sometimes when we're out at a mobile service, you only have 20, 30 minutes with somebody because you have a huge line of people. And this actually allows a little bit more flexibility for our psychosocial officer to make sure that the people have, it could be 30 minutes, it could be an hour, and it doesn't matter, because we're able to schedule slightly differently this way. So I think that's some of the reasons that we went to going virtual itself.
Yeah, that makes sense. Thank you.
Okay, maybe I just want to share about what we did in Indonesia after our local government implemented the large physical distancing. As all our CSO staff in Indonesia, they used to work face-to-face. And when the work from home policy started to be implemented, all the strategy shifted to online or virtual. So we focus our case management activity actually with the goal how to maintain all our clients that already on ARVs will still on the ARV treatment. 4 things that critically important in our virtual case management are: first, we make sure or ensuring all clients could be contacted virtually. Here, we ask all our CSO to virtually contact all their clients minimum once per month. So they may use like a phone call, or if they cannot reach the client with the phone call, maybe they can use the online online platform like Facebook or Instagram. And then the second thing, we also help our CSO partner by providing the list of guidance questions. So our CSO partner or our CSO field staff will use this list of guidance questions when they contact their clients. The list of guidance questions included about how the clients feels, especially with this COVID-19 situation, whether they feel depression and so on, and also whether they had opportunistic infection, or how about their ARV stock, how long their ARV stocks will still last. And also, we also ask about whether they already got the COVID testing and so on. And for those who never got COVID testing, we will ask also the risk assessment questions. And the third things that's really important for us is about data collection. Like Ben also mentioned before, at the beginning we try to use Excel form, but we struggling about we and also our CSO partner found it struggle to use the Excel form. So we changed to use the form and put it in the Google form. By using this Google form, the CSO field staff found it lots easier and not time consuming compared with when they use the Excel form. And the fourth thing that really also important is about regular communication and coordination. So to maintain the communication, coordination, and monitoring between us and our CSO partners, and also with all the CSO field staff, we conducted a weekly regular meeting with all CSO, which we conducted like 2 times a week, one for all the program managers, and the second one we conducted special weekly coordination meeting and monitoring about all the activity with all the CSO field staff and their supervisors. So in here, all our CSO partner may share how they struggle with to contact their clients and how they successful in contact their clients, because in some, maybe in CSOA, they may reach their client by using key person and so on. So this virtual case management strategy that we conducted actually proven to be effective with some dramatic data, such as we successfully contacted around 95.6% of all our clients that on NRV, which means it's around 2,834 clients. Our CSO successfully contacted them every month from March to June. And out of them, about 99.8% of them are still on ARV even until now. And what also exciting for us to see that in quarter three, our case managed clients actually slightly higher than in quarter 2, which is from the COVID situation. So by this data may show that although or despite the COVID situation, by which we shift the strategy from face-to-face to virtually, the case management can still be conducted and it is quite successful. Maybe that's from Indonesia. I hope that can help, or maybe can give like what else? What is called? Actually can show what we did and what we got in Indonesia.
Okay, yeah, thank you. So yeah, I have Purvi rightly mentioned about this the limitation. So in comparison to face-to-face conversation, than virtual. So Laura, so psychosocial counseling is as also you have mentioned, so it's a kind of like in-depth conversation and the two-way conversation. So like using like body language, and then how like do your like virtual psychosocial counselor manage this this kind of things while providing virtual psychosocial counseling? So sometimes no, like while like having virtual mentoring or like support or monitoring or training. So it looks like sometimes we are talking with the screen or talking with the phone. No, so can you please explain so how your virtual psychosocial counselor are like dealing with such situation?
No, I think I mean, that's one of the things that we're trying to kind of figure out right now is initially what we're finding is that for some cases, somebody will somebody will contact her and they'll book through this online system and they'll say they want a discussion, but when she calls, they're very vague about everything. And it's much harder for her to kind of get them to pull it, to share more information and to get them to disclose what they're comfortable to disclose over the phone. So she has found that, you know, for cases that normally might be done in like one session, she's now having to do 2 to 3 different sessions with them to kind of get more of the information. So I don't know if that answers your question. But I think especially for psychosocial, it's just a different way that we're having to look at it and to do it. Because yeah, you know, I think that face-to-face, and especially when people are disclosing such as emotional abuse, sexual abuse, like it's really complicated, and there's just a lot of nuances that I think are generally seen in that face-to-face. But I think she's finding different ways to kind of to learn how to talk with people and to get them to, you know, feel more and more comfortable online. I think we're also trying to see if maybe we can do a little bit more in terms of awareness prior to getting to her. So people are like, it's going to be on the phone, you know, so make sure you're in a place that you're comfortable. She'll ask questions. But yeah, I mean, I think we're trying to learn as we go and see how to adjust as it happens.
Okay.
So I mean, that's what we're learning. Yeah.
Okay, thank you. So yeah, one of the lessons learned so while doing virtual case management, so mobilizing peer champion like virtual influencer, like here in Nepal, so we mobilized virtual influencer. So the PLHIV, who the first and only PLHIV, people living with HIV, individuals living with HIV, who summited Mount Everest, the highest peak in the world. So we mobilized him to promote adherence and retention, and then regular viral load testing. So it was also very popular among PLHIV and useful. And also we also mobilize a transgender activist who is also HIV positive. So mobilizing such virtual influencer is also like very popular and useful to motivate PLHIV who are not willing to come out and then go to access service, and who are not non-adherent to ARVs. And and providing regular mentoring and support is also useful and helpful to get motivated, as well as feeling a sense of connected. So these are some lessons learned we learned. So can you please mention some of the lessons learned you have learned implementing virtual case management? Thank you.
I think in Indonesia, we work closely with our community service, community organization that based on key population. So we work with CSO that focus on the MSM group, and the other CSO focus on the female sex worker and people using drugs and so on. And every CSO field staff, they have they have the responsibility to manage their own clients. Like for one field staff A, they have responsibility to manage like around 10 or to 20 clients per month. And to make sure, yes, like Laura said, I do agree that at first maybe the clients with psychosocial, maybe they feel not really comfortable to shift the communication from face to face to virtual, so that we ask our CSO field staff to still contact our clients at minimum once per month. And even if our the clients or the PLHIV still needs time to talk and so on, the field staff can still provide the time. So if the first time they contact the client and the client still not comfortable, and the field staff may ask, okay, when will be the comfort or the available time for you that you could be more comfortable to talk with us. And that also happened with the MSM staff and MSM CSO staff, and also about the female sex worker. Maybe that's a lesson learned from us.
Okay, thank you.
That actually answers my question also, because I was just thinking that if, in this COVID situation, when people are actually locked up in their homes with their families in close proximity, how comfortable would PLHIVs be to talk about adherence, especially if the family is unaware about their status? And so I thank you for answering that question, Lucy and Laura as well. Having said that, I think one of the major lessons that we learned through our implementation was that, people are not yet ready for a self-care kind of modality to actually look out for services online on their own. And I think virtual case management through a case manager is actually helping them cross that bridge from a face-to-face modality to a completely self-care virtual modality. And that is why I feel that, that kind of follow-up through a case manager gives like a personal touch to the client, makes him feel more comfortable, and also kind of motivates the client to go in for the services actually. So that was a lesson that we learned, that, that personal touch is still required till we actually help clients cross that bridge. Thank you.
Yeah, you are right. So yeah, so because of the yes, we are dealing with sensitive issue. Still, the stigma and discrimination is around in the community and family. And then so because of the COVID-19 pandemic, so yeah, it's still like a personal thoughts, or like face-to-face conversation and communication is still has importance. Yeah.
I just want to say thank you guys. I really enjoyed this discussion, and I don't know, I miss all you guys because I haven't seen you guys in so long. But I know it's helped me. A couple of things have kind of just popped to mind of what we can do in country to kind of help move some stuff forward. And I know I'm really looking forward to like the rest of the presentation as a whole. But thanks, guys.
Yeah, thank you, Laura, and thank you. Yeah, it was a wonderful discussion, and it's really interesting to share and learn from each other. Yeah, thank you very much.
Yeah, this was a new outlook that I saw on virtual case management as well. Yeah. So thank you so much.
Yeah. Okay. Bye-bye.
Thank you so much.
All right. Thank you, Fishies. You did an amazing job. You each get an Oscar for Best Actor in a Supporting Fishy Role. Okay. Thank you all. I've noticed that many questions have come in under the chat and into the Q&A. I see that Carlos has a question, Daniel's a question, and Sepriem has a question. Please go ahead and copy your questions from the chat. Put them under the separate Q&A feature, because that's where we're going to track our responses to those questions. So our panelists, if you can please open up the Q&A aspect, the Q&A piece. And I believe Bhagwan has reviewed some of these. And Bhagwan, is it that you wanted to respond to Tiffany's question?
Yeah, I think, yeah, we have like addressed this confidentiality and vulnerability. Yeah, actually, so yeah. So while like contacting the PLSI clients through phone or social media, like while during the home delivery of ARV drugs. So we first like take consent from them. So, and then also ask like appropriate time for them, also the place. So if they do not want to like meet at their home, then we meet into the like appropriate like places that they mentioned. So we have not faced any like issues around like the media. And regarding this, the how many clients per virtual case manager. So generally, so it depends upon like Laura mentioned. So it depends upon the types of cases. As we discussed, so the virtual case management also saves like travel time. So that we can serve more like people. So because of the like saving of travel time, generally. So sometimes 2 or 3 or 4. So it depends upon the cases, no, like how long it takes to interact with the PLHIV or like clients. Thank you.
Yeah, so I think that was Carlos's question around confidentiality and supporting clients through virtual platforms. I mean, some things that we typically recommend is that the case manager, when they call a client, they confirm the identity of the client. There's some ways that this is done. In the US, providers always ask about the date of birth, which is not perfect, but it's one way. And there's other ways to do it as well. You can offer to open a video chat for a moment just to look at the person, make sure it's them, and then close it and do a voice. And also the case manager should also be verifying their identity. And that can be done probably a number of ways. But it's most important at that first call. Like in India, Harvey was saying that they get a call from a new case manager who's being assigned to them for the first time virtually. So they need to really be sure that they're building that trust and giving some proof of who they are and who they represent. So we have some other questions. So I think we've addressed most of Carlos's. And I will recommend that our panelists go in to the questions and they type their responses for ones that we do believe that they can provide some insight into. And also, currently we have four panelists. Are any of you looking at these questions and have any that you would like to answer live?
So this is Laura. I'd love to answer the question about if we have one person who's following a client, or do we use a team approach? And I think it kind of links on how do we coordinate between the community and facility services. So we generally have one person that kind of once they start a discussion with somebody, they continue on with that discussion. And we are doing this now, we are also doing this, we kind of have a hybrid approach of both the online and the offline for both the PSS as well as the care and treatment side, which is all currently done virtually. And one of the things I actually love about this, the quick res, the Aura, is that my linkage case manager that is tracking our positive cohort and our prep cohort, if they have issues or they see a need to escalate, they're able to talk to the person and say, hey, I have somebody else I'd love you to talk to. We often have them, we refer them to our psychosocial officer. And right then and there, they can make an appointment. They say, let me make an appointment that works for you. And you're going to be talking to this person and she will call you on that time. And so this happens. We do this with our outreach workers, our peer navigators as well. If they see an issue, they just talk with the person and they book an appointment online and they kind of let it know who they're going to be talking to. So whenever we do transfer somebody to when we escalate it, we do let them know. And I find the online reservation has just really helped reduce the back and forth of people, because then it's like, oh, I can't do it that time, I can do it this time, because now the schedule's just there. So I find that to be one of the benefits right now of the quick res in terms of the escalation of needs. Thank you.
Thank you, Laura. Other members of the Fishbowl, other questions that you'd like to address live?
Yes, I think I would like to answer about how our self notify or identify ourselves with a client. So we working together with our CSO field staff, and rather than they said their client or their managers, they usually use the termination peer support. So we're here to help, and we both from the same group. We all I also PL HIV, I also like MSM and so on, and it makes the client also more comfortable and more trust the CSO field staff. And and also our CSO, we facilitate them to communicate and have a communication and regular meetings with the health services. So when sometimes our CSO cannot contact the clients, the CSO actually can contact the health services staff and asking whether their clients still come and whether their clients still on ARV and so on. So how to make the clients feel comfortable with the CSO staff. That's all.
Yeah, so I would like to answer this criteria assessment tool. Yeah, we do not have a tool as such, but so we prioritize to those clients who are non-adherent to ARV drugs and who have virally unsuppressed. So and then who have not started treatment. So yeah, we prioritize so based on this criteria. And regarding there is one question regarding viral load suppression compared to those follow-up on face-to-face. So actually, yeah, we have found a bit like a high number of virally unsuppressed people living with HIV during this lockdown period, and we are trying to get the case details, and so we are also collecting the case details virtually. So once we have these case details, and then we can have like more detailed information why there is like increased number of the people with viral unsuppressed. Yeah, and then regarding this, actually I answered already. So we are mobilizing our existing staff like peer navigators or like paramedic staffs virtually. That's why they are paid. So just actually they are before lockdown they are providing case management services in person, face to face, but during the lockdown so we like rapidly like changed our to the virtual case management. So they are the paid staff. Yeah, thank you.
Hi, so I wanted to try answering the question with regards to privacy and confidentiality of client data. So with regards to, the data that is available on Aura, if we talk about the online reservation application, we don't collect any personal identifiers of clients except for a phone number, so that we can enable all the follow-up mechanisms with the client. And so, identification of a particular client is not that easy for anybody in terms of breaching confidentiality. The other thing is that every case manager has been given a login ID and password and can only view people that have been, allotted to him as a cohort. There can be certain sections of the backend data that can be hidden from the case managers if there is an issue with regards to HIV testing data or status or anything of that sort. Then there are options where it can be hidden as well. So it all depends upon what you want your case managers to really do, and what role do you define for your case managers, and who are the case managers. Because if they are counselors, then they probably know the status of the clients, and then they would be doing similar kind of work, and the issue of confidentiality then does not come with those clients, because they've already done post-test counseling with the clients and they know their status. So it all depends upon who your case managers are and what kind of work do you want to allot them to do. But there are various ways in which we can ensure that privacy and confidentiality is not breached of the clients, and we train our case managers to do that. So locking of phone devices or having passwords for data sheets and things like that is a common practice that we follow in going online. And so yeah, I think we are capacitated enough to deal with that kind of an issue. Thank you.
Yeah. I just wanted to add one. So in addition, so our staff, like the case manager, so they signed oath of confidentiality, like Purvi mentioned. So we have trained them to maintain confidentiality and the privacy, and we reiterated and highlighted like sensitivity during the while using the virtual case management. So yeah. And there is one question regarding the role of PLHIV network for virtual case management. Actually, yeah, so this is very like a good question. So actually here in Nepal, so national network of people living with HIV played very crucial role and important role to provide home delivery of ARV drugs during the lockdown, and also like connecting PLHIV to ART sites, and also the virtual case management. And we linkages Nepal. So these networks, this network is one of the implementing partners of linkages Nepal. So, and we also collaborated with NEPN National Network, and also the National Network of Women Living with HIV to reach this PLHIV virtually, as well as like in person in case of delivering ARV drugs at the home of PL. And also we coordinated and collaborated with them to access PLHIV relief package services, because these times during the lockdown, in addition to ARVs and the treatment, so they also need like food and nutrition and other supports. And the National Network of PLHIV played an important role to provide these services. Yeah, thank you.
I also think that the PLHIV network can act as an influencer for the program, actually. If you know, because most PLHIVs are involved with some network or the other, it would act as an influencer to actually build that trust with the program, and then the case managers can take a lead, or the program can take a lead to actually follow up with clients and link them to their various services. I think it would be a great idea for influencer strategy.
I just want to add a brief. So the PLHIV, actually in Indonesia, we work with the PLHIV networking to our specific program we call Lost and Link, or how we find the clients that already lost to follow up and will return them back to the services. And this also regarding the issue of confidentiality. So the local government or our provincial health services initiated the regular meeting between the health services and our CSO, and also the PLHIV networking. And every month they will look at all the clients, all the data, which already lost to follow up, and about missed appointment. And then the health services will ask the help from the PLHIV networking to try to find out all the lost to follow up clients. That's all. Thank you.
Thank you, team. I think we've addressed almost all of the questions. There are some that are also coming in. We don't have a ton more time for these, but I was really happy that we could have you highlight these issues from the field. And I think it's been an extremely useful exercise. So thank you all. And you can go in and you can respond by typing your response to these new questions that are being added to the Q&A field. So let's move ahead. We're gonna go to the next slide. And we're going to do a very quick poll to help us just as the participants consider where we are at with virtual case management. So let's go ahead and respond to this poll. Are you not implementing and not considering implementing after hearing this? If you're considering, or if you're in the stage of actually planning, are you piloting? Are you scaling your implementation, or have you already scaled and you're looking to improve? So let's go ahead and respond. And if you're at a higher level, such as the HQ staff or donor, you can respond based on a particular country that you're supporting or a particular project. We'll just give ourselves a minute here to see this. This will be very nice as we move into the next section on planning rollout. All right, let's go ahead and give your responses, and let's reveal the results. Okay, great. Great. Okay, so this is very useful. Everyone on the call is in the right place. If you're not implementing, and now that you've heard about it, you're not considering, you can drop off. No need to stay on, but it looks like everyone is at a stage of considering and planning. So planning is really great. Some are already in the phases of implementation. So let's go ahead and close this, and we'll go to the next slide. All right, and we'll go to the next slide. So at FHA 360, we are consolidating these frameworks and set of tailored procedures for virtual case managers, which can be adapted to country and program context. We have Shanti Noriega, who's a consultant with us and who's leading the development of this guide, and she'll give you a sneak peek into the guide's specific procedures for case managers, including what are the virtual components within each. So go to the next slide. Here, I won't go over these. These will be specified in the guide, but we're really going to want to look at when planning to consider when virtual case management is appropriate and when it's less appropriate, namely when clients have mobile phones where they can be contacted, or program staff have devices, maybe Wi-Fi or mobile connectivity, or where case management teams are not located near to the clients. And this may not be a great approach if clients don't have access to a mobile phone or safe access to a mobile phone, confidential, private access to a mobile phone. Of course, you want to have several considerations for how you adapt this. There's so many different kinds of staff that can act as a case manager. It could even be an outreach worker if they have the training for certain things, such as post-test counseling. It can be HIV counselors, psychosocial counselors, peer navigators, social workers, clinicians, and then also specialized case managers, which can take on this sort of new role that can span parts of the cascade. And as part of adaptation, you'll really need to have a strong process of mapping out the handoff between different people. I won't get into this, but of course, there's lots of technology requirements, including, very importantly, on the case management system that you use. Depending on the system you use, it has varying levels of utility for case managers to really provide that tailored support. So we're going to show you an example of the online reservation and case management app later. Of course, considerations for security, which were mentioned in our Fishbowl, training, rollout, and budgetary considerations. So we'll be sure to put all that in the guide. So go to the next slide. And here, I'll hand it over to Shanti, who will present some of these procedures that we're going to be highlighting in this forthcoming guidance. Shanti?
Great, thank you, Ben. So before I go into the details of the procedure section, I really wanted to share with you a few principles that we're applying for the guide's development and how we've conceptualized each section. So I think it's really important to make it clear that we're really building on existing program guidelines, tools, and SOPs. And this guide is really just focusing on providing steps for case managers and programs to be able to apply these existing tools virtually. And although we focus on virtual case management in biomedical interventions, we do include sections that help programs and staff understand how virtual approaches can be used to enroll people and bring people into ART and PrEP services. So some specific components that we're covering in the guide currently include HIV post-test counseling. We discuss index testing and the initiation of ART or PrEP. And under each of those sections, what we've done is we've specified virtual case management and communication goals. And while we acknowledge that these goals might be quite similar, regardless of whether you're engaging with a client face-to-face or in person, our procedures then really focus, again, as I said, on helping those case managers use these existing tools through virtual approaches. So the way this section is going to work is that I'm going to present each of these different service areas, and then Ben will be sharing examples throughout to demonstrate how this is done using FHI 360's Aura application. Next slide, please. Great. So when we talk about post-HIV testing and counseling and service linkages, the case management and communication goals really focus on making sure that clients understand their HIV status and that they're linked to services. So in the guide, we're using examples of phone-based post-test counseling, and the guide includes steps to really help counselors overcome any of the differences and challenges that they face when they're not providing this service face-to-face. And some of the specific topics and tools that we use include how you initiate post-test counseling over the phone. And we include scripts to really help counselors confirm the person that reaching is the correct person. So this is, like Ben mentioned previously, confirming date of birth or some other identifier so that we make sure we're talking to the right person. We confirm contact numbers in case the call is disconnected. We provide guidance for the counselors to introduce themselves and assure confidentiality. And we provide counselors guidance on how to reschedule calls to a time that's convenient for the client. So kind of linking to what Laura had mentioned previously around really making sure that this is a convenient time for clients and that we really are prepared and able to provide some of that follow-up, more in-depth counseling that might be needed. A second topic that's covered is around communication and ensuring that clients understand their test results. And here we're applying a know, believe, do model and adapting motivational counseling techniques and undetectable equals untransmissible messaging to virtual delivery. So the guide provides specific guidance and example scripts to adapt to virtual settings for counselors. And the counselors can use these during phone-based post-test counseling to help clients navigate through the process of understanding results and the service options available to them. And we include additional tools like open-ended questions so that we can assure that clients are understanding key points throughout the post-test counseling session, as well as a template for a service directory to help counselors and clients decide on what services to access and where they want to access them, and also provide steps for the counselors to facilitate online reservations right at that point. A final section that we include describes steps and guidance that counselors can use for reaching out to clients through phone calls and SMS in the event of missed appointments or for initial linkages to ART or PrEP service providers. And so with that, I'm going to pass it to Ben, who's going to share an Aura example.
Great, thank you, Shanti. I'm going to try to share my screen. I do believe that, yes, I'll need to have the presentation end and I'll share my screen. Okay, give me one moment. And I'll share my browser. So here I just wanted to show you QuickRes, which is a version of the online reservation application that's multi-country. And just very quickly, you'll be able to see here a client reaches the website at quickres.org, and they can go ahead and start and do a risk assessment to see what services are right for them, chat with program staff, or immediately book services. And here's the full list here. And when you click on HIV treatment, for instance, it'll pull up the clinics that offer that with their schedule, and they can go ahead and book. So that's how it looks on the front end. And this is how it looks on the back end. So this is a view of all the clients that are booking across all clinics in this country. And this is the administrator view. The administrator view is allowing me to see the client name here, the clinic where they're booked. And you can see here, these are the actions that the clinic is selecting for the services they provided during the appointment. You have arrival, HIV self-testing, HIV testing, co-infections like STI, Hep B, Hep C, TB, ART linkage is here. And so they're marking these options. But of course, as a case manager, I will have my own login. I'll only be able to see clients assigned to me. So let's go ahead and sign in as a case manager. So these are all, of course, fake reservations that are for this demonstration. And I'm demonstrating how to do virtual post-test counseling and linkage to ART. And this is done. You can see that I'm assigned all these clients on the system. And my job is to then support clients who have arrived. So I select arrived. And of course, as a case manager in this instance, I'm not seeing what the clinics are reporting. I'm just seeing that the client did arrive. And then I know here that for Rexmore, this person has arrived, but I've not offered them PrEP or ART, and I didn't note here that I finished the post-test counseling. So what I'll do is I will find their phone number here, which is hidden unless I hover over it, call the client, say that, oh, have you been able to attend your appointment? I'm here to provide you follow-up services, whatever the protocol is, and then help this client to be able to navigate to PrEP or ART services. And I can note that here, such as being able to report here PrEP initiation, referral, and if it's initiation, typically it'll be referral first, they'll save it, and once I call back again to confirm initiation, I can update it. I can say initiated, the date when the client said that they initiated, or maybe I have a relationship with that clinic, so I know to call them and get that information. Depends on the relationship with those clinics, and I can report that there. So that's an example of how you can use a system like this for case managers to follow up with clients for post-test counseling. I'm going to hand it back over to Shanti to describe the next section.
Great, thanks, Ben. Okay, so the next section, could I have the next slide, please? Next slide. One more. Great, so the next section is around the topic of virtual index testing. And here the focus is really on helping clients understand the importance of index testing and providing clients with options to reach their partners and family members, and includes anonymous options for them to use as well. So adapting motivational counseling skills to a virtual setting, the guide really provides steps and related scripts for case managers to use on phone calls. And this is really aimed at supporting clients to decide on index testing options that are appropriate for them. The scripts include how to conduct follow-up calls to discuss index testing with clients in the case where clients have not yet decided if or even how they'll share contact details. Steps are also provided to help clients consider virtual methods for anonymous client-led or provider-led options for recommending their partners and contacts accessing HIV testing. And it also helps case managers explain to clients how this is done via messaging or on the phone, and how to explain and obtain consent. Guidance is also provided to help the case managers support referred partners and contacts so that they're able to make the reservations for HIV testing by phone or online. And similarly, how to access follow-up services such as post-test counseling service linkages, and eventually index testing for those who are diagnosed HIV positive. So Ben, over to you.
Great, thank you. I'll go ahead and share my screen again, and we'll be on that same view where we're looking at the reservations assigned to me as a case manager. And here we're looking at how we can know when a client should be offered index testing and then facilitate that offer. So really, we're only looking at clients who I have said on my end are initiated on ART. I do that by selecting the ART button. So here I have my cohort of clients that I'm following in ART care. And I see here that I've already offered index to Buzz Turner, okay? And then we have Ben Test. So Ben Test, it looks like here that he was initiated in January, and they had 90 days medication dispense. That was when they were first initiated. Of course, their refills are going to show up under other appointments, but I'm going to track their index offer on their original record. So what I can do here is I can first start by possibly contacting the clinic where they initiated and ask, did you offer index testing? If not, I can help you do that with the client by phone. And then they can start by then, if the clinic hasn't done so, contacting the client with the phone number here, and start that process of educating on index testing, the importance, and then starting with the offer of the options. And so on this system, there are a couple options. I'm going to review two, provider-led and client-led. Provider-led, if I select it, it allows me as a case manager to open up this portal where I can enter the phone numbers of this person's sexual partners. And it will have up to 5 fields here that will send this message to those clients. And this can be done without notifying those individuals beforehand, or it can be done by me noting the phone numbers here and asking this person living with HIV, my client, if it would make sense for me to call them up beforehand and explain the process and say that they will receive an SMS with a link to book an appointment, and I can help them do that. And then I can go ahead, after calling each one, I can then send, and the SMS is sent from the system. And this means that it's protecting the identity and the anonymity of the index client, because an SMS message is being sent from this quick res system. It's not being sent from the client that is doing the referral. But I can be the interface with these people who are being referred and help them to understand that they're going to receive a message. And I can go ahead and do that. This other option, I'll open it up again, is client-led. Client-led is where when the button is pressed, an SMS is sent to this client with a link for them to open up this page and do this themselves. So then the client could do it completely anonymously without telling me, the case manager, who their partners are, and with me not being able to contact those partners. Or that client can say, hey, I'm going to contact each of my friends, let them know that I'm going to send them a message, and then I'll send them the message from the system. And the reason why it's important to go through a system like this is that the booking link that they get in their message is actually linked with a code to the parent. So this is a reservation code of the parent, meaning the original client living with HIV, so that we can track from seed to referral, index client to the referred partners. So that's an example for index testing. I'm going to hand it back to Shanti. Shanti, let's just review the ART section, as I think that the prep initiation part is going to be quite similar, and we don't have a lot of time remaining.
Okay, sounds good, Ben. Could I have the next slide, please? Great. So this really gets us to the heart of the VCM guide. And here the case management goals focus on achieving viral suppression, while the communication goals really focus on assuring clients understand the importance of adherence and also generating demand for virtual case management. And these are the same goals, communication goals, that we have for PrEP. Some examples of what the virtual case management guide provides under the section include steps for case managers to assess client readiness for virtual services. So this is a really critical first step, where we include guidance on how to discuss virtual case management options and outline the pros and cons with clients, so that clients can better understand exactly how virtual case management works and what it means to them in terms of their personal information and what it means in terms of expectations at each step. We also provide key considerations for when case managers communicate with people living with HIV using virtual platforms, particularly where there might be concerns and questions around confidentiality and safety. And we also developed a mock template for a pamphlet that describes virtual services to clients. So this is something a client can take away with them so that they can better understand how virtual case management works and what to expect along each step of the way. And finally, we have a template case management plan that case managers can use with clients to identify those services clients are willing and able to access virtually, and those that might require face-to-face interaction. And the guidance is also included there to how to complete this, with key considerations for each of the different services to help case managers and their clients complete a case management plan. The guide also includes a section related to electronic case management systems, similar to what Ben's been demonstrating, and how they're used to collect and review client-specific information. So this includes an overview on alerts the case manager receives when clients access services, reminders to the case manager for when follow-up is needed, and detailed case management notes that help tailor any follow-up or routine phone call, video call, or SMS. So bearing in mind that case management evolves over time, the guide also provides case managers with suggested frequency of calls and example topics of discussion for calls and SMS messaging at the initiation, also on the maintenance phases. So Ben, I'm going to pass it over to you one last time.
Great, thank you. Let's go ahead and remove that PowerPoint. I'm going to share screen again and do a demo very quickly of the steps for a case manager to use QuickRes or Aura to support clients through routine ART adherence, initiation adherence. So an example would be when you're supporting a client to return to facilities for ART refills. The way that this is done is you can search for a client by their name or their phone number. The phone number is unique, where the name very well may not be unique. Currently, Ben is the only Ben on the system. So this way I can pull up all of the appointments booked on the system with Vin and Ben. I can equally use his phone number. So let's just use the phone number to be accurate. Okay, here we have all of his appointments, and the case manager can use this to be able to see the record where the client was initiated on ART, okay, the amount of days of medication dispensed, and they see that it was done in January, and they can use that to calculate when their next appointment should be and help them come in. And it looks like you see here, this appointment is a refill, 90 days, and you can look at the date again, and that's in April, so it looks like this person's on track. And then here's another ART refill, 90 days. And it looks like this person is on track because that was just last month. So this is a way that case managers can use the system to support clients over time. They can also see that this client initiated 6 months ago or longer, and can use that to determine what support package they provide to the client. Maybe it's around time that they can start moving to quarterly check-ins, etc., if they're doing well and virally suppressed. And also on the original appointment record, you can see that ART clients shows up, where for the refills, it does not. So this is opening the option to report each quarter the status of the client, so that there can be a log of the retention of the client on ART in one place on their record for each quarter. So this means like the amount of ART dispensed at the last amount, and that they were on ART during this quarter, and then also viral load. So this allows the case manager to have one place, one original record to view the status of the client each quarter. And then of course they have these future, after these appointments afterward that are about refills or other service access. Let me go ahead and stop sharing my screen, and let's go back to the slides. We are over on time, and I would like to thank everyone for your patience. I was very happy with, very pleased with the Fishbowl activity, and I want to thank those participants for sharing their experience and highlighting field level knowledge there. And great, so we'll go to the next, we'll go a few slides later to the thank you slide. And we'll go to the Going Online team slide. So here is our team of specialists, and including not here is Shanti and Abraham, who's also supporting this team. If you have any questions about Going Online, you can email us at goingonline@fhi360.org. And if you register for this webinar, you're going to receive an email with the slides, the webinar recording, and you can also find in the slides this link to join a WhatsApp group that's public, where we discuss all of these and related issues to bringing HIV services online. All right, well, thank you everyone for your time, and enjoy the rest of your day. This has been a great webinar, and we look forward to seeing you on the next webinar. Goodbye.